or support keeping children in the homes as opposed to foster care placement. So again, it's not new money. And oftentimes when we talk about something new or a new initiative coming into the state, we're thinking that there's going to be some new additional monies, and it isn't. It's really using what is already available and actually channeling in another direction. So we talk about who's eligible for services and what are the services that have been approved. Eligible for our services are children who are candidates for foster care, and we'll talk a little bit more about that later. Pregnant and parenting or parenting youth in foster care, as well as their parents and their kin caregivers of these children and youth are eligible to receive services. What are the services that they're eligible for? We're talking about mental health treatment, substance abuse prevention and treatment services, as well as in-home parenting and skill-based programs. So how will Family First function in the state of Connecticut? Family First is part of Connecticut's overall prevention strategy. As you can see in our little diagram, Family First is just a small portion of what the state intends to do as we look towards prevention services across the state for all families. It is really a collaborative effort across all systems to really provide prevention services and early intervention to families to prevent children from entering into our child welfare system. And we'll talk about that more. You'll hear that over and over again as I go through. But what is really key for Connecticut's Family First program, and unique as we would like to think of ourselves, is we have an upstream population, which means that we're really looking to provide supports, services, and interventions for families before they come to the attention of our child welfare system. So what are some of the outcomes that we're hoping to achieve? We're looking at that upstream approach, as I talked about before. Again, it's reaching families before the children or before DCF becomes involved. It is an enhancement in our current service array by providing more evidence-based programs and practices, making them available throughout the state of Connecticut, reaching families to some of the more rural parts of the state to ensure that the families can receive what is necessary so that they can remain together and our children can stay safe in the home. It's also establishing some oversights and standards to our residential treatment programs, which I'll talk about later. And then we talk about that coordinated approach. We really want to go across all our systems, bringing all of our programs together, our sister agencies, as well as our community and grassroots organizations to provide these wraparound and supportive services for families. In addition to that, we have in our model, our kinship navigation model, which is to provide some additional supports to these families that traditionally don't receive these additional supports. Before I go on, are there any questions, or you just want me to roll through and you want to ask questions later? But I don't want to skip through something and someone has a question.
Hi, Dr. Davis. I would suggest that since we have such a large group that we ask everyone to put their questions in the chat. And then when you're ready to stop for a moment, I'll read them out to you.
Okay, so if you have any in the chat, because I am not watching the chat, if there are any questions, you can stop me and tell me.
I will watch the chat.
Okay, thank you. So when we talk about the work and how was this approach in the state of Connecticut, and I think many of you probably remember long before I actually arrived into this position, more than 400 community partners, we're talking about sister state agencies, community organizations, contracted providers, advocates, and most importantly, parents and youth with lived experiences came to the table to develop the plan. We had more than 100 families register and approximately 44 families participated in the planning and the development of Connecticut's plan. And that was really important to us because we needed to have that voice. We needed to understand the caregiver's experience in bringing their expertise to the table to help us to develop the plan. Some of the things that we realized as a result of their involvement in this work was that it was really important for them that we provided that advocacy and that peer support to our families. And we'll talk a little bit about that later. We talk about our kinship navigation model. In addition to that, it was really important for the focus beyond families and families' needs, but families really being in the driver's seat to identify their needs, not having someone actually come to the table and say, well, these are the things that you need, and this is what we're going to do for you. Families wanted to have their voice heard. Families wanted to know that the services that were being provided were services that they wanted based upon how they saw the needs, saw their needs and how their needs could best be addressed. So here is our candidacy population. We have two candidacy populations, which we feel is just very unique, unlike a lot of other states and jurisdictions that have Family First approved plans. We have our known to DCF population, which are families with accepted care line calls, our pregnant and parenting youth in foster care, as well as siblings of youth in foster care. In addition to that, our community pathways population, which I'll refer to as our upstream population, is really very broad. Our hopes is that through Family First, we'll be able to reach all families across the state of Connecticut that raises their hand and say, oh, I have a need, and can someone help me? So we feel that this population is pretty broad, and hopefully we haven't missed anyone. What is unique about Family First is that there's no income test required for children or families or even kin to receive these prevention services. And all families will receive the needed services regardless of the funding source. Connecticut has enhanced its existing evidence-based programs to make them available within the local communities so that our families can remain safely together. Approved in our plan are 7 well-supported evidence-based practices selected based upon the families known to DCF and the needs that they have identified. Now, we recognize that these evidence-based practices may not be the ones that will meet the needs of our community pathways population, because again, they're unknown to us until they actually come into the door and request some services. But this is where we're going to start. And our hopes is that as we continue to grow and looking at our future state, that we will receive some additional funding to provide some more specific evidence-based practices and programs for families and our community pathways population. So how does one receive Family First services? Federal legislation requires that each child has a child-specific prevention plan, which means that once the child has been identified as being at risk of foster care, removal and placement in foster care, but in order for that child to remain safely in the home or temporarily with a kinship caregiver, these services are made available to keep the child safe. So all children under the Family First Prevention Services Act must have this child-specific prevention plan. So what is the prevention plan? This plan will assess the family's strengths and needs through a family strength and needs assessment. It will identify, along with the family's input, the evidence-based programs and services that are aligned with their identified needs and what was necessary to maintain that child's safety. In addition to that, this prevention plan will provide the ongoing monitoring of the family's progress. So as I talked about a little bit earlier, we see this as an opportunity to serve all families when we talk about our Family First services, especially our upstream families. And the way into into our Family First program services is going to be no wrong door, if I can say it that way. Our plan really defines our community pathways, our upstream families, as those families with specific conditions, behaviors, or circumstances that are likely to have an adverse impact on a child's development or functioning, even if there's not an immediate safety concern or a functioning that might place the child at risk of entering foster care. What Connecticut believes is that if we can provide these services to our families sooner, they may not even need to come to the attention of our child welfare system. And we look at that as a great opportunity to really help families to establish that stability and well-being and keeping our children safe.
Dr. Davis, we do have a couple of questions. I don't know whether this is a good time to stop, or do you want to wait until you have a good time to stop?
I'm ready.
Okay. The first question is, how do we get involved to become heard or integrated into the residential treatment oversight program? Not sure that that's something that you can answer, but do you know?
That one, I don't know, but let me take that question down and I can get back to you on that.
Okay, how about if I keep track of them so you don't have to write them down right now, all right?
Okay, that's
Okay.
fine.
And then the second question is, what does Family First do about a child in a home where parents are actively using drugs or being physically abused? Are the children going to stay in the home while they receive quote unquote in-home care?
If a care plan can be developed whereby the family will engage in services and accepted resources to keep the child safe, and it has been determined by DCF that the child's safety is not at risk, a family can receive Family First prevention services and the child can remain in the home. However,
Okay. Go ahead, I'm sorry.
if the child is removed from the home, the family is no longer eligible for Family First services.
Okay, and then the last question that's been entered so far is voluntary services. Will voluntary services be available for youth who are involved with the juvenile delinquency court / juvenile probation? We often see the delinquency court reach out to DCF for services due to the fact that they can't receive voluntary services through Beacon.
Are we talking about VCM, the voluntary care management services, the VCM currently offered through Beacon?
Dave, why don't you turn on your mic and ask this question, because I know you have some very specific concerns.
Yes, I believe that's the service I'm talking about.
Yes. Our VCM population is part of our community pathways population, and those youth are eligible for Family First services.
Was it always that way, or is that something new?
This is new.
Okay, all right, because there was some confusion, I think, when it was getting off the ground that those families could not receive the voluntary services through the voluntary Beacon program. So that's good to hear.
I'm going to jump back. If the youth falls under, when we look at our community pathways population, youth who've been referred to JRB, YSB, or another diversion program are eligible for Family First services. Is that helpful?
Yes, that is. Thank you.
Yeah.
And Dr. Davis, I think this question from Maria Brereton is a clarifying question. I think it'll be helpful to some of the folks on here. It says Family First is not a program, correct? It is my understanding that it allows the child welfare agencies to claim more IVE dollars for services previously not eligible for reimbursement. Is there a fiscal I'm sorry. Is there a fiscal plan to allow for more funding to come to nonprofits, given the state will get additional federal dollars?
Family First is not new federal dollars. The state will not receive additional federal dollars under the Family First Prevention Services Act. What it means is that the state will receive 50% reimbursement for the evidence-based services that are afforded families. In addition to that, the state will receive 50% reimbursement for training of evidence-based services, and as well as the administration of evidence-based services. So where a referral is being made to an EBP that is approved in our plan, there is reimbursement for that. But understanding Connecticut's system, any monies that is reimbursed, federal dollars that come back to the state actually go into the state coffers, so that those dollars do not go directly back to DCF.
Okay, and then I'm going to go through these next two questions, and then we're going to wait until Dr. Davis gets through more of her PowerPoint, because I think some of this is stuff you're going to be looking at. One question is, what are the exclusionary criteria for Family First? Is that later on in your PowerPoint?
When we talk about exclusionary, we're talking about who's not eligible for Family First?
Correct.
Got it? Okay, so I'm glad that I left the slide up, and I hope that you can see this slide. All families are eligible for Family First services. The only time in which a family or a child is not eligible is when the child has been removed and placed under the care and custody of DCF. Those children, those families are not eligible for services. So the family must be able to remain intact. The child must be in the home, and in the home whereby it has been determined that the child can remain there safely while the family receives services. Once the child has been removed from the home, Family First services stop.
All right, and then this next one, I'm not sure how this applies, but will a family's income or insurance status determine their eligibility for voluntary services if under the Family First?
The under Family First, families are eligible for services. However, if a family has insurance, the insurance can be billed, but Family First funds will be used as the payer of last resort. There's no supplanting of current funding or insurances that one has. If in the case where DCF is currently paying for a service, they cannot use Family First funds or you claim under Family First for those services until they have first spent their dollars, and then Family First is the payer of last resort.
Okay, I'm going to let you keep going and hold these next questions until at least 9:45, just so that we know that you have enough time to get through your whole PowerPoint.
Okay, that's fine. And I think I left off on this particular slide here, you know, how will Family First, how will the community pathways function? We talk about having a case management entity, which will be an agency organization outside of the department. We're really responsible for engaging our families. The department heard very early on from families and partners that it was really important to develop this entity outside of the department to manage these cases. We are currently in the contract negotiation phase for the care management entity to engage our community pathways families, to provide that case management, to manage our service referrals, and to monitor families' ongoing process. And this really came about as a response to the feedback, and we're really thrilled about the prospect of establishing this relationship and really capitalizing on an exciting opportunity that Family First really affords us, providing services for families without having that over the DCF surveillance of families as they receive services and begin to really heal and to stabilize. So when we talk about our community pathways and what is our care management entity responsibility? The goal is really for our families to be served upstream or as far upstream as possible, again, without involving DCF in the process. So our care management entity will be responsible for evaluating for child safety first. And if there's a safety concern, a call will be made to the care line for further evaluation. The entity will collaborate with community partners to identify and engage potentially eligible families and children. They will engage our community service providers, establishing that connection, and then as well as reaching out once a family has come in and raised their hand requesting services. Really try to establish that connection, that rapport with families before conducting an assessment and really helping the families to focus on what their needs are and the goals, and then helping them to determine what services are going to best meet the identified needs. They will assess for risks and strengths. They will help to develop the case plan, and they will work with the families for service matching. Again, they're also responsible, again, for that frequent and ongoing contact with our families as well as with the service providers to ensure that the services are meeting the family's needs. And if not, taking the time to do a course correct, sitting with the family and working through to identify what may be more helpful in meeting those needs. In addition to that, because Family First is a 12-month model, if I can say it that way, they're responsible for meeting with the family on at least at the 11th month before the 12th month to assess what is going on with the family, to determine if ongoing services are needed. And then another eligibility determination has to be made, which turns out, if I can say, the switch for DCF to ensure that the family receives the services and that the providers are reimbursed for services delivered to our families. So there are two other pieces in our plan, and that is our qualified residential treatment programs and our kinship navigation model. So there are three important aspects of our qualified residential treatment programs. There are new licensing and accreditation requirements. All programs that are approved to be our QRTPs, as we refer to them, must have a trauma-informed treatment model and nursing and licensed clinical staff available 24/7. In addition to that, the discharge and aftercare planning must be in place for at least 6 months post-discharge. In addition to that, in order for a child to be placed in our QRTPs, there must be an assessment to determine whether or not the child's clinical needs are best met in a residential setting. These assessments are conducted by our RG staff here at the department, responsible for really ensuring that this placement is appropriate, and then making that recommendation to the court, who ultimately approves the placement of the child. The third component of our QRTP is the family engagement aspect. It is important that families are part of the treatment process. They're engaged in the decision-making, in the placement, the ongoing care, as well as the post-discharge care of the child. So when we talk about congregate care, so it doesn't mean that we're limiting placements in congregate care, but what it means is that federal funding now really restricts and makes us take another look at placement of children beyond 2 weeks. No longer can a child linger in a residential treatment program. The placement is for a very specified period of time. If it is recommended that the child stays longer, there's a process, an approval process that must occur that is signed off by our commissioner that ultimately goes into our courts for the final approval with justification that the child's needs can best be met by an extended stay. The goal of our Congregate Care Reduction Act is an emphasis on family placements, and whenever possible, we're really trying to keep children at home with their families as much as possible, but sometimes a child's needs cannot be met, and that time away in a residential setting is going to be the best and most appropriate level of care for the child. The other aspect of our plan is the kinship navigation model, and there are 3 components to that. We're looking at community partnership, providing that referral assistance to our families, coordinating care services across the continuum of services throughout the state for our families, the identification of persons with lived experiences that will serve as our navigators, working alongside with families, providing that support and that advocacy, and helping families to negotiate through the maze of social services, as well as the other services that are available throughout the state. So when we talk about our plan, What we propose is a phased implementation of Family First. We felt that we should begin first initially with providing services for our known to DCF families, as well as our voluntary care management families with accepted referrals. Our intermediary phase was really to develop our care management entity and putting out that RFP, that bidding process whereby someone would be selected to provide that service. And our secondary phase was really the delivery of Family First services to our community pathways population. So the question I'm wondering if anyone has is, so where are we today? We find ourselves fluctuating between the three phases. We have completed the RFP process, and as I mentioned earlier, we are now in the process of negotiation with our care management entity with the hopes of onboarding and opening up for services sometime late spring, early summer. And we feel that we're really on track for that. And with our community, with our known to DCF families, we feel that we're almost ready. There's a few things that we still need to work out, most specifically our IT infrastructure to ensure that the information is received and shared between our community pathways, our care management entity, our community pathways families, as well as the service providers delivering the EBPs. So for many of you, you probably know that Connecticut has been in the work of Family First since 2018. And so we've been doing this for a very long time, and we find ourselves with a few challenges. A lot has happened. COVID has occurred. For those of you that know, the state experienced the silver tsunami of 2022, resulting in a loss of expertise. Our internal workforce became tired. It's just a lot of work that had to be done in a short period of time. We really wanted to fast track this process and get this plan up and running as soon as possible. We found ourselves in that CME procurement process, which was very competitive. And then our final challenge was our caregivers, and our youth with lived experience. And I'll talk a little bit more about that. So to keep the momentum going, we recognized that we had to be consistent. We had to stay the course. We had to re-energize folks. We have a video that was developed by our commissioner. We're working on offering train-the-trainers. In addition to that, we had to build some refreshers internally just to remind some and to orientate others about what was going on with our approved plan. As times went on and people went on to other assignments and tasks, a lot of folks forgot about the work that we were doing. And when we brought them back to the table, we recognized that we were back at square one. So we recognized, bringing back those work groups, again, there was the refreshers, but we also understanding that folks were tired. We had to rebrand and refocus ourselves, moving from planning to implementation and really casting that vision as to what does it look like now and where are we going. That meant that we had to identify some champions across our agency to help us carry the message of Family First. So just a little bit about the procurement process. It was very competitive. And because we knew that it was going to be a competitive process, for the first time since the onset of Family First, when we're talking about planning up until now, our community has been very much involved in the development of the plan, and we've had you involved in some aspects of our implementation. But this is where we had to pull back and close the doors and develop the RFP internally because we knew that it was going to be competitive. We did not want to eliminate or prevent anyone from applying for or competing for this for the CME grant. So in order to keep the community as well as our own internal staff engaged, we rethought our communication strategy. We did involve our some of our families with lived experience in the business process for our non-DCF candidacy population. We did involve one provider that I can remember in that process. Also, we developed a monthly newsletter, and I'm not quite sure how many actually saw it external to DCF, but of course, if you haven't, I'm happy to share that with you. And also, we had to really look at providing presentations ongoingly about Family First and talking about our implementation to ensure that the community was aware, knew what we were doing, and because we really wanted to keep that transparency, we wanted to keep the momentum going, and it was really important for you to know that you were still a part of this process. But we still have, as I talked about earlier, we still have our challenge, keeping our parents, caregivers, and youth with lived experience engaged in this work. That is an ongoing challenge for us. We recognize that there's some things that we've done that we could have done better. There's some things that we know that we have to go back to the table on and just regroup and think about what is important to ensure that our families, our parents, as well as our youth are at the table and that they're being heard and know that they're being heard. And what they're sharing with us is actually impacting the work that we're doing. So when we talk about Family First in the future state, what is it that the state of Connecticut is looking for? Less child welfare involvement and more family engagement, engaging families so that they're empowered to building those relationships, having that regular contact, but also families knowing what services are available so that when a crisis does occur, they know where to go. We look at our community pathways as being that one place where families can go to receive the supports and services they need in a very private and confidential way without DCF involvement. But ultimately, we want to equip our families to feel safe, to be safe, keeping their children safe, and living and stable. So just a little bit more about our future state and the stability. What is the long-term goal for Family First in the state of Connecticut? We would like to establish an infrastructure in our private sector, connecting more with 211, building technology around information flow between our agencies, developing that reimagining campaign whereby the agency can be reviewed as a prevention-oriented agency, not just a child welfare agency. We want to expand our evidence-based practice footprint, ensuring that the evidence-based services and programs that are available will meet the needs of every family in the state of Connecticut, whereby we're not totally dependent upon the federal government and Family First to provide that reimbursement for only those services that are in the clearinghouse, but we like to bring more evidence-based practices that will support our families in the state of Connecticut. And then the other thing is just demonstrating to the state that the reimbursement return is just a good investment, which will leverage our acts for additional dollars to just expand beyond what Family First has to offer us. And did I lose my screen share?
Nope, you're good. I still see it.
Oh, you can, because my screen just dropped on me, so I don't know what happened. Okay, all right. So, okay, I'm back. I just lost my signal. So I just want to thank you for your time. And if there are any questions, I'm going to come off a screen share.
Yeah, so let me go through the questions that we've gotten in the meantime. So Catherine asks, are the 7 programs, the evidence-based programs, in addition to what we already have? For example, we already have FFT and MST. Will these be additional slots?
The answer is, the hopes is yes. We don't really know what the true need is right now for our Family First, especially our community pathways families. but we're hopeful that we're going to meet the need. And through the McV funding, if it's necessary, that is where we can actually ask for additional slots to meet the needs.
Okay, and then the next one is from Maria. Given the general fund will have increased dollars, is there a discussion about increasing financial support for agencies?
That is not a part of the Family First plan.
Thank you. And then Patricia asks, will undocumented families and children be eligible for Family First?
Yes, all families in the state of Connecticut are eligible for Family First.
That's good news. How would the CME be different than care coordination services that are already available? Kelly is asking.
We envision the CME as being a little bit more. We're looking for the CME to be that warm handoff, someone that will be able to meet the family where the family is, meeting families in places where they're going to feel safe, comfortable. The CME having a really good understanding and relationship, not only with the family, but with our community, and engaging families where they're at. I think in a lot of ways we can say that is our current care coordination model. But we were hopeful in thinking in our planning that it's really a little bit more than that, a little bit more enhanced.
Thank you. Dr. Davis, I will be able to receive a copy of this PowerPoint so I can share it with everyone, correct?
Most definitely. I'm going to
thank you.
As soon as I've finished, I'm going to push the button for you.
Okay, Catherine asks, have the CME organizations already been identified, or is this step yet to occur? My agency provides PAT and HFN.
The department is currently in discussion with the contract negotiations with an organization that has been identified to provide the care management services for Family First.
Okay. And then next question is from Patricia. Our QRTPs. Let's try to explain what these initials are for as we say them, because I'm sure there are a lot of people on this call that don't know what they are. So our QRTP is located in each region for accessibility for families to participate in treatment.
QRTPs, Qualified Residential Treatment Programs, as we know them today, and as you know them formerly, were your group homes and your residential treatment programs. So they're located throughout the state of Connecticut. Sergio might know a little bit more about where they're located, because that's not something that I'm very much familiar with. The only difference is when we talk about QRTPs is that in order for Family First to receive Title IV-E reimbursement for this level of care, where all of the residential treatment programs were asked to apply to become QRTPs, which is another designation, understanding that the length of stay will be very defined, families will be engaged. We're using that trauma-informed lens to our treatment modality. In addition to that, we're talking about a level of clinical and nursing staff that will be available to families 24/7. So they're your current residential and group homes now that are in place. And it's my understanding that all of the residential and group homes in the state of Connecticut are now QRTPs.
Thank you. I think you already answered this question, but has a CME been identified? Is that where you said that you're still in negotiation?
So there's formally, no.
Okay. How will the CME assess for safety? Will they use an SDM model? What is SDM?
Structured decision-making model? No. So structured decision-making model is something that's used internally for DCF. So we're working with them to identify what type of safety tool they will use to ensure that children are safe. Part of their training will include the ABC model, the safety practice model, to ensure that the language that they use will be the same language and understanding that DCF uses, so that when a referral or call is made to the care line, they're very clear as to what they've identified in their reporting.
Okay. And then will the CME be handing off to subcontracts with local providers?
No, the CME will not contract with local providers. The CME will be responsible for the care coordination and referral to the evidence-based practices approved in the plan, as well as any other wraparound services that the family may need or could benefit from.
Okay, so Troy has a number of questions. So he was the one who asked about the SDM model, and he wanted to know how the engagement will be monitored, and will the CMEs have wait lists? There are long wait lists for services now, and it often results in mandated reporters making unnecessary reports to DCF.
There will not be a wait list for the CME. The CME will accept all referrals that are made, conduct an assessment to determine whether or not the family's needs can be met through Family First. If the family is not eligible for Family First, then the CME will be responsible for coordinating services for that family other than the services approved in the plan. I know that was one part of your question. The first part of your question was
how will engagement be monitored?
engagement will be monitored through our child-specific prevention plan. Approved in our plan is the ongoing contact with families. Right now it is quarterly that they should be meeting with families, but the expectation is that the CME is going to have contact more regularly than that with families to ensure that families are connected with the service provider, reaching out and speaking with the service provider to ensure that the family is engaged in services, and then having meetings with both parties to ensure that the family is happy and the family has continuing to move forward in stability and well-being. So is it very prescriptive? No, it's not going to prescriptive time and frequency of visits. That's really going to be developed on a family by family basis.
Okay. The next question comes from Maureen. How can needs-specific community advocate organizations be referred to families and get paid for their services under Family First?
Family First, the Title IV funds under Family First will only reimburse for those evidence-based practices approved in the plan. So there is no reimbursement for services outside of what is approved. So we talk about those evidence-based practices. Do I go back to them? That was FFT, MST, PAT, NAP.
So I think, Dr. Davis, that I think some of us are just concerned that this may eliminate the ability for more grassroots organizations to be able to work with families. And my understanding is that's not the case, that if Connecticut wishes to engage in any kind of contract with anyone else doing any other kind of work that's not under Family First, that's a separate conversation. Is that correct?
Yes, and let me just add a little bit more. Currently, the contracts that Connecticut has or that department has for families, that remains the same. So services, the CME can refer to those additional services. Those providers will continue to receive their reimbursement, their funding, the way in which they're currently receiving it. Family First does not change that structure. The only thing that Family First is going to do is to reimburse for those 7 evidence-based practices that are approved in our plan. The CME will be responsible for referring families to other services and will use wraparound funds to support the other needs that families may have.
Okay. And then Kristen's asking, will the CME refer families to community agencies that are providing programs such as PAT and HFA?
Yes.
Okay.
They're approved in our plan.
All right, and Patricia asks, if a family or youth is unhappy, what is the process for submitting a complaint?
If a family or youth is unhappy, we're going to hope that they're going to communicate that back to, if we're talking about our community pathways families, because we have two populations, that we're going to hope that they're going to communicate that right back to the care management entity, and that the CME is really going to be responsive to address those needs. If the CME does not do that, and I'm going to say thank you for the question, because we had not really thought about if there is a mechanism for that. And I would probably ask you all the question, where do families currently report problems or unhappiness? Is that the Office of Child Advocate? Is that?
I think it's there. I think it's also through the Office of Community Relations at DCF. I think it's also to, you know, the chain of command in whatever agency that they're working with. But I do think it's an interesting question in that you do want to monitor that.
That's a very interesting question, and thank you for that. Something for us to really think about. I guess we're under the impression that everyone's going to be happy 100%, and that's really not realistic.
Are families connecting to the CME only through DCF, or can other community providers access the Family First programs? That's from Catherine.
Our goal is that Family First connection to the CME will be through the community. We're looking at it as a no wrong door in. 211 will be one way to access Family First services through the CME. Schools, community providers, families can refer themselves. And referrals can come from DCF to the CME.
Thank you. So Trish is asking, how was it determined that the state needed additional case management services? In my experience, there's an abundance of case management available to families, but a fire shortage, I don't think that's the right word, of direct care clinical dire shortage, thanks Trish, of direct care clinical services.
How was it determined? Under Family First, the determination really came from the community. Service providers as well as families themselves felt that the best way for them to receive services was through someone other than or outside of the department. They felt that in some cases, they did not really need DCF's hand in services that they received. That's how it came to be under Family First. So it was the voice of the community to determine that this particular type of care management, case management, was important to meet their needs.
Okay, so I was waiting because someone had asked if they could ask a longer question. Melanie, I did see you. And I would like to encourage everybody to put their questions into the chat. But Melanie, you said that you'd like to ask a longer question. Please do unmute.
Thank you. I'm a little bit concerned about the CME model and the care coordination when we talk about DCF really having a push towards equity and giving access to smaller, more grassroots providers, mostly that are providers run by people of color. And this CME grant did not allow, it actually disallowed for any subcontracts into any communities that already have relationships with families, and they're already providing care coordination services in the communities that we live and work in. And this care management entity was a large dollar amount, I think $8 million, for there to be phone care coordination or care coordination and connecting people back to communities, but no dollars are coming to the communities and where people live and feel comfortable getting services. This seems to sort of fly in the face of DCF saying that they wanted to and always encourage local subcontracts with smaller grassroots providers. And in New Haven in particular, as we have been, we're on year 4 of the Integrated Care for Kids initiative, where we are working with DSS to make sure that we're giving grassroots providers the ability for the first time to potentially bill Medicaid for care coordination. There hasn't been, and the intent of that program is for it to become statewide. It doesn't seem that this initiative is working well with that initiative, and nor does it seem like this is an equitable process for people who are already providing services and have relation and are in relationship with people in the community.
I'm going to agree with everyone in the chat. Great question. It was something that we kind of grappled with as the department looked at the development of the RFP and the design for the care management entity, and how could we best implement it. Some of the things that, some of the issues that were raised when we talk about our care management entity was that it needed to be an organization operation that really could reach across the state into all of the areas of communities to ensure that services were equitable. The difficulty in some of the conversations that were had very early on was that no one had raised their hand having that ability to actually do that. One of the things that I think that you saw in the RFP was it was even open to city entities, organizations to whereby we felt, or it was felt, that they would have the infrastructure to meet that need. The biggest difficulty for the state of Connecticut is, you're right, in some of the larger municipalities where there's access to services, because there's transportation, which is very much different to some of the more rural parts. If you're in the north west part of the northern part of Connecticut, there isn't any public transportation. So the concern was, how could an entity reach the needs or engage families and ensure that families could reach services there? Now, that's still going to be a challenge for the current entity identified to be the care management provider for Family First. But it was also thought that that was even more difficult for the smaller. And then I have to say, when it was posted, there were some limitations to it in the design of it. Can I really explain why? But I think a lot of that had to do with also being able to ensure that the needs could be made, and how much dollars, the dollars that DCF had to fund this contract.
Can you speak to the equity piece? Because if DCF has consistently said that they want there to be local subcontracts, and if you have this large singular entity that only there would be certain people that would be eligible to do it because of the infrastructure issue that you mentioned, then you're giving $8 million to one entity, not spreading out among providers that are already doing this work with much smaller DCF contracts, enormously smaller DCF contracts. And you're not sharing any of the dollars within the communities. And that I would like an answer to sort of the equity question.
I cannot speak to the equity question. The development of the RFP was done through our leadership. This is what they felt that would best meet the needs of the community. In all fairness, you did what was written in our plan, did not actually communicate, or was not actually communicated through the RFP. You're right. And as it's written in the notes, it sounds too much like orchestration with not enough musicians.
So I just wanted to highlight that. I understand the limitations of state government, but the fact that this seems like a very inequitable process, and the opposite of what DCF is saying that they're trying to do as it relates to community.
So Melanie, I'm going to ask that we move on because Dr. Davis's time is limited, but you brought up some very good points, and I know she's going to take them back to leadership to let them know that these are the concerns of the community. Our next question, actually, I think this might be more of a comment than a question. from Maureen is historically families feel their complaints and concerns are not welcomed, investigated, remedied, or warranted. An identified quality complaint mechanism would be helpful. So I think she was just agreeing with Patricia that this is a very good idea.
Yes.
Yeah.
So no.
And just looking to see if there's anything else somebody wants to know, when do we have any idea when the announcement will be made about who the CME is and how we can, and when implementation, or when they will become, active?
We're hoping by late spring, early summer, that we will have finalized the contract negotiation, the contract will be executed, and that our leadership can make a formal announcement.
Okay. I personally have a question about the kinship navigation piece. Is there going to be a website developed so that our kinship caregivers will have access to being able to, at 2 o'clock in the morning, go on a website and start to look at what services and supports are available to them?
The kinship navigation model, that piece is being headed by Natalia Morano. I can forward that question to her and have her get back to you.
Okay. I'll write that down for you and send it with the other question.
Got it. Yep, thank you.
All right, and then are there any other questions? Because we got to the end of the chat, and I just want to make sure that if anybody else has any questions, you can either raise your hand at this point, or if you can type it into the chat, that would be great. It doesn't look like there are any. Oh, Patricia raised her hand. Go ahead, Patricia.
Good morning, Dr. Davis. I just wanted to know if the services for those children that are juvenile justice involved different or going to be the same, or are you going to expand on more services for them?
Currently under Family First, the only services that are being, and we go back to reimbursement because that's really what this is all about, and really ensuring that families are afforded the evidence-based practices that are available, and there's only 7. So those services our juvenile justice youth are eligible for, but the hopes and the goal is in the future state to really expand the evidence-based practices for that population, as well as the other populations in our community pathways.
Thank you.
Dr. Davis, I know that there's only been 7 evidence-based practices that Connecticut has been approved for in the plan. Will that expand? Will we be going back after the first year, looking at what else has been approved by the clearinghouse through which we need to choose, so to speak, that there's a clearinghouse? I can't remember what state it is. Is it California?
Yes.
Yeah, the California clearinghouse lists the programs that we're allowed to choose from in implementing Family First. Will we be able to go back as more services are approved and say, oh, this looks like a good program for Connecticut, we're going to change over or add to our service array?
We're looking to add to our service array. One of the things that we're currently looking at now is motivational interviewing. We found that across the country and other approved Family First programs, that motivational interviewing is currently being used. That's one that we're actually in discussion about now to add to our plan. In addition to that, as we continue to, as our care management entity is onboarded, working with our families, identifying needs, we will have a better understanding as to what EBPs are available for those families. And then a plan amendment will be submitted to include those EBPs specific to our community pathways population.
Go ahead.
One of the things that we're also looking at this time are any EBPs for our human trafficked, sex trafficked population, and just having discussions with other jurisdictions, we recognize that there's not a lot of work going on in that area, simply because we have not, and many have not been able to identify any practices that are on the clearinghouse or even eligible for review by the California Prevention Services Clearinghouse. So if you're aware of any, we would love to hear what's out there, what's currently being used, and how we can actually begin to work with having that approved by the clearinghouse, because that is one of our community pathways populations.
Thank you. I have one more question. So all of this obviously is going to be new to us. And if DCF identifies that they're not seeing the number of referrals that they anticipated based on the populations they identified, are we allowed to also go back and adjust the populations that are eligible for Family First, or that are, that have preference for Family First services?
I believe that everything is open for discussion. The goal here in Connecticut is to ensure that all families receive the services necessary to keep our children safe and families intact. So I think that that's a very fair request.
Okay. Does anybody else have any other questions that they'd like to pose, or any comments that they'd like to make at this time? By the way, I apologize because we were a little discombobulated at the beginning because Dr. Davis was having a hard time getting in, and other people were also calling me behind the scenes telling me they were having a hard time getting into the meeting. But we are recording this meeting so that if you need to review what was said in the meeting, you will be able to access that. And I will be sending that out to everyone who attended.
Dr. Davis, I want to thank you for joining us this morning and giving us an update on the prevention plan for Connecticut.
Mm-hmm.
I know it's a lot of work. It's not just about you, it's the entire system. As I said earlier, there's been a lot of stakeholders, a lot of partners that have worked on this plan. And of course, there are things that perhaps we didn't think about early on when we were developing the plan that now we're starting to think about, such as some of the questions that have come up today that are excellent questions. Melanie, hello, I haven't seen you for a while, but again, I want to thank you. We know it's very complex, and the ultimate goal is to ensure that our families are getting the services they need, and that we're partnering together, not just DCF, but our community child welfare system to do that. So again, thank you. Deb?
Yeah, so Dr. Davis, I do have one last question for you, which I know will be of interest to our attendees. Would you be willing to come back again once the CME has been identified, and perhaps do a joint presentation with them on what this is going to look like once we have a better idea of implementation and moving forward?
Of course, most definitely. And I think that the contracted will be more than happy to do that, because one of the things that we really have to do is really get the message out, and coming into rooms like these, it's going to be very important for them to let you know not only what they're doing, but also to open that door for referrals and resources. So thank you so much. I want to thank you all for allowing me to come in and to speak with you today. And even for the really hard questions, because I think it's really important for the department to know what you're feeling, what you're thinking, and how what was planned really didn't line up with the reality. And I really would encourage you, and I know that it reached my ears, and I'll take it to other ears, but I would really encourage you to also share that to the other ears within the department, because we're really working hard to make sure that this is something that families are going to benefit from. But when we look at the inequalities across the system as it relates to our care management entity, it's important for us to be mindful of that, because now is really the time for us to really begin to make sure that if we're going to make those changes and implementing something into our infrastructure, that we start very early on.
Thank you.
Thank you.
So unless anybody else has any last questions, I'm going to close the meeting. And Sergio, if you could just stay on so that we can talk about how we go about getting all the information to everybody. Thank you, everyone, for attending. And Dr. Davis in particular, thank you so much for your time this morning and for putting together the presentation. I look forward to receiving it in my email so that I can share it with everyone.
Sending it right now. Thank you, everyone. Have a good day.
Thank you.
Bye-bye.
Take care, everyone.